ملك عاد ابن الظلم العفريت بتاع النظافة
نظافة.
We'll start in 3 minutes. Inshallah. Dr. Faraji, can you confirm that you're here with us, please?
I'm here.
All right. So can you please share your screen? We'll start in 3 minutes.
Sure. Good.
We're just waiting for people to join us, Dr. Faraji, and then we'll start. Thank you.
Ahmed, we can start right now.
All right. Thank you, everybody, for joining us today in our scientific session. And on behalf of the Egyptian Society of Radiology and Nuclear Medicine and the Geology Department at Bena University, I'd like to welcome you all to the 36th scientific session today, coordinated by Dr. Hisham Sheikh. And it's my great pleasure and honor to present Dr. Navid Faraji. Dr. Faraji is an assistant professor of radiology at the Musculoskeletal Division at University Hospital and Case Western Reserve University in Cleveland, Ohio. He also serves as the Associate Program Director of the Diagnostic Radiology Residency. And Dr. Faraji will give us a talk today about basic shoulder MRI. It's a great pleasure having you with us today, Dr. Faraji, and thank you for your time and for your sharing your knowledge.
Yep. Thanks so much. Thanks so much for having me. I appreciate the opportunity to come talk to you folks, and hopefully this will be a useful talk for you. So I'm pretty casual. I'll just forewarn you that feel free to interrupt or chat questions as we go. I'm happy to answer them, and we'll get started. Okay. So just a few things about me and the things that I love before we get started. This is a sport. I'm not sure if you folks are familiar. It's known as ultimate frisbee. It's kind of a mix between football, like European football, soccer, and except for you're playing with a flying disc. And as you can see, this guy in the right upper image is falling on his shoulder. And this is, with an outstretched hand. This sort of blunt trauma can result in glenohumeral dislocations, and we'll talk a little bit about some of the imaging sequelae of this type of injury. But it's it's a sport played by all genders, and I'd recommend giving it a try if you haven't yet. It's fun. One of my favorite things to do. And just a couple other things before we get started. This is my dog. His name's Rumi, like the Iranian poet. And it's our cat Bibi, which means queen in Farsi. And this is our cat Grady. And just a little thing, these are some of our residents here in Cleveland, Ohio. Our first year radiology residents. This is a nice view of the skyline where we live. And it doesn't compare probably to some of the things you folks have, but and then here's a nice image in the fall when the leaves begin to change colors. It can be very pretty. My screen is black.
Oh, I believe it's good.
It's good? Okay.
Yeah.
Okay, good. Okay, so before we start talking about pathology, I always like to start with the basics. So it's important to know the anatomy and normal anatomy before we start talking about pathology. So we'll have a few slides on that. And I don't have poll everywhere set up, but we do have some questions that I'll prompt you to take a gander or look at. So here's just a couple schematics of the rotator cuff. So we're going to start with rotator cuff, and then we'll talk about the labrum. We can see here is a posterior view on the left and an anterior view on the right. And so there's four major rotator cuff tendons and muscles, being the supraspinatus, infraspinatus, subscapularis, and teres minor. Three of these insert onto the greater tuberosity or tubercle, and one of them, being the subscapularis, inserts onto the lesser tuberosity or tubercle. And so I kind of like to use the names rather than memorizing what goes where. It just helps me to kind of understand the anatomy a little bit better. So we have the spine of our scapula here, and it stands to reason that the supraspinatus is above or superior to the scapular spine on the dorsum of the of the scapula. And then obviously below the spine, we have our infraspinatus, and then teres minor is below that. And then the subscapularis is the only one that's on the anterior surface or the undersurface of the scapula, hence the name subscapularis. And the subscapularis we can see here is depicted with its multipennate tendon architecture, in contrast to the remainder of the rotator cuff tendons, which generally have one like major tendon insertion. This has a multipennate tendon architecture. And it's the only one, the subscapularis again is the only one that's on the undersurface of the scapula. And similarly, it's the only one that inserts onto the lesser tuberosity or tubercle. So here we are, we can see on this lateral view with this is an actual humerus. We're looking at it laterally with the rotator cuff, obviously dissected here. Anterior is to the right of our image and posterior is to the left of our image. And we can see here's our lesser tuberosity. And here's our greater tuberosity. And we can see that the supraspinatus inserts onto this more superior facet, and which has a more horizontal orientation. Then we see a more obliquely oriented middle facet and a more craniocaudally or vertically oriented inferior facet. And these changes in morphology correspond to the changes of tendon insertion. So supraspinatus, infraspinatus, teres minor, and we'll see that on some MRIs as well. And here's here's a view from the posterior where we can see the vertically oriented inferior facet of the teres minor insertion, this more oblique infraspinatus tendon insertion, and this more horizontal supraspinatus tendon insertion. And this was nicely depicted in this paper by John Jacobson et al. In radiology, again, showing the superior facet, middle facet, and inferior facet. And I've kind of simplified it by saying the supraspinatus inserts onto the superior facet, whereas the middle facet is where the infraspinatus inserts. But we can see here nicely that there is some overlap in the middle where, I kind of call this area the common tendon, where you will have some tendon tearing of both of these tendons if there is a tear in this region. And then last but not least, we can see the long head of the biceps tendon here, which courses in this intertubercular sulcus or groove between the lesser tuberosity and then the greater tuberosity. So we'll talk about which plane I really like to evaluate the long head biceps tendon at some point. And here's another anatomic depiction from Chicago Sports Doc on Twitter, also demonstrating nicely the anatomy of the supraspinatus, infraspinatus, and teres minor, which has a smaller insertion posteriorly. So I like this histopathologic paper that talks a little bit about the vascularity of the rotator cuff. And similar to some other tendons in the body, like the Achilles tendon, where there's a relatively avascular zone or critical zone, this rotator cuff, supra and infra, have a similar avascular zone where there's a lot of vasculature coming from the musculature. There's some vasculature coming from the osseous insertion, but in this area, this critical zone, about 1 to 2 centimeters proximal to the insertion, there's a relative paucity of vasculature. Now, if rotator cuff pathology was a result of a paucity of vasculature in this area, then we would suspect that the rates of injury of the supraspinatus and infraspinatus would be similar. However, we know that the supraspinatus is more commonly pathologic than the infraspinatus and much more pathologic than the teres minor as far as incidence and frequency is concerned. Then there must be more to it than that. So there's both some intrinsic reasons as far as paucity of vasculature, but there has to be also some extrinsic reasons that cause this difference in frequency of injury and frequency of pathology. So there's extrinsic causes and intrinsic causes of rotator cuff pathology. For example, like subacromial impingement might be a cause of extrinsic pathology, which we can talk about here in a little bit. And while we will be concentrating mostly on MRI, I think it's prudent to take a look at a couple of radiographs here. And I want to zoom in here on this scapular Y view that we're all familiar with. And we can see our humeral head is nicely in the center of our scapular Y. And this shows us nicely this supraspinatus fossa here, a suprascapular fossa. And we can imagine here, this is where our infraspinatus would be. And maybe this is the shadow of our teres minor. Posteriorly, remember, our acromion is our landmark for posterior, and our coracoid process is our landmark for anterior. And I think it's important to remember that because not always on examinations are we given a stack of images that we can scroll through. And in order for you to better understand what's anterior and what's posterior, you have to have an idea of landmarks that are given to you. So if I see the coracoid process in an image, then I'm pretty sure I'm looking at the subscapularis muscle or tendon, especially if it has a multi-pennate tendon architecture. In contrast, if I'm seeing the acromioclavicular joint, then I know I'm probably a little bit more posterior and looking at either supra, infra, or teres minor. So coracoid again, anterior, acromion, posterior. And then here's an AP projection, again, showing just that we can imagine that our supraspinatus myotendinous junction would be around here, and the muscle and tendon would be coming and inserting here onto our greater tuberosity. And you can imagine if someone had some acromioclavicular arthrosis with some osteophytes that maybe were projecting inferiorly, or maybe their acromion is downsloping laterally because we have different acromial morphologies, that these sorts of processes can impinge upon the supraspinatus myotendinous junction as it traverses here when the patient is continually abducting. If someone is like working in a factory or like shipping and they do a lot of overhead activities, then this repetitive motion can cause some intrinsic compression of the tendons, especially in the setting of acromioclavicular arthrosis or acromial morphologies with some lateral downsloping. So I like to just imagine when I'm looking at radiographs, and similarly, like if we have mineralization in the region of the greater tuberosity or tubercle, then we could suggest the possibility of calcific tendinitis or calcium hydroxyapatite deposition. And so it's important to keep in mind which structures and where they are relative to each other on radiographs. So if we're doing MRI of the shoulder, we know that the shoulder girdle is not in the same plane as the rest of our chest. So it's incorrect to say that it's just a straight oblique of the shoulder, because then that would not be in a great plane to lay out the rotator cuff in its long axis. So we actually do oblique coronals and oblique sagittals because the shoulder girdle and scapula is approximately 30 degrees angled anteriorly. So rather than doing a straight coronal, we also angle our imaging planes, image acquisitions, to make sure that we're looking at the rotator cuff in its actual true long axis. So we do oblique coronals, and then and perpendicular to that is how we get our oblique sagittal, so we can look at the rotator cuff muscles and tendons in their short axis and be able to see the signal intensity within them quite nicely and their insertions quite nicely. And then axials are just true axials from cranial to caudal. We can see, at any individual slice in the coronal plane or axial plane, we'll be looking at the labrum anteriorly, posteriorly, or superiorly as little triangles, and we will we'll talk about that a little bit further as we go on. So I've got some images here, some stacked. So this is a fluid sensitive image we can see, because joint fluid or relative paucity of joint fluid that we see is kind of bright. In addition, we can see that it's fat saturated because the bone marrow is generally hypointense and the subcutaneous fat is generally hypointense, aside from these areas of poor fat saturation and aside from these areas of physiologic bright marrow or hyperintense marrow in this skeletally immature patient that still has some hematopoietic marrow that's still red marrow. So I'm just going to go through briefly my algorithm of how I go through this coronal plane imaging. So I will allow this to play. So we can see here, again, this is our coracoid process. And one of the first things we see is our conjoint tendon from our coracoid process, which would be a short head of our biceps and the coracobrachialis tendon. And as we course posteriorly, we begin to see the multi-pennate tendon architecture of the subscapularis going from medial to lateral. Tendon, 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 tendon. So tendons in normal MRI and their normal state are hypointense on all pulse sequences because they're well organized, well collagenated structures, not a lot of mobile protons to get excited. But when they are pathologic or edematous or have some infiltration by fluid, then they become a little bit increased signal on fluid sensitive sequences, indicating some tendinosis. And there's varying degrees of that, from mild, moderate, or severe, just generally on how thick the tendon has become and how much abnormal signal is within the tendon. So again, here's our subscapularis. We can see the base of the coracoid process, and we're going from anterior to posterior now. And we're going to see the subscapularis coming and inserting here onto the lesser tuberosity. And as we go posteriorly, we begin to see, here's our long head of the biceps tendon coming and originating from the supraglenoid tubercle in the superior labrum. And, you know, your first slice, excuse me, as we course posteriorly, the first slice posterior to the long head biceps tendon will be the leading edge of your supraspinatus tendon insertion. So that's right here. So the first slice, and now we see the first image of supraspinatus tendon insertion, although we do see some supraspinatus muscle and tendon anterior to that as we course posteriorly. So you want to look for your long head biceps tendon, because the next slice posterior to that is where you should be looking for your supraspinatus tendon tears. And generally, the supraspinatus tends to tear, or the rotator cuff from the greater tuberosity, you know, supra tears more than infraspinatus and much more than teres minor. And then they each individually tend to tear from anterior to posterior. Not every patient is the same, obviously, but so it's really important to look for that leading edge of the supraspinatus, because that is where we would expect the most common area of tearing to be. And also, in general, the tendons of the greater tuberosity tend to tear from the articular surface to the bursal surface. So every tendon in the rotator cuff has an articular surface, which is the deeper surface closer to the joint, and a bursal surface, which is the more superficial surface and closer to the subacromial subdeltoid bursa. And then I haven't covered this, but the subscapularis tendon tends to tear from cranial to caudal in general. So we're going to go again. Here's subscap. We're going posterior. We see some supramuscle tendon, and then we see the long head biceps tendon coming up and over and inserting here. And we can see that this patient is nicely externally rotated. Okay, that's what brings this long head biceps tendon so lateral here. And so it's important to keep in mind that not every patient is going to be externally rotated like this, because not every patient is able to tolerate that. So if they're not, then your long head biceps tendon, rather than being all the way over here, may be more anteriorly positioned, and therefore your leading edge of your supraspinatus tendon may be a little bit more anterior. You may see it a little bit earlier in this coronal plane imaging than you might expect in a patient who's able to externally rotate like this. We see a little bit of superior labrum here as well. And then we're going to go posteriorly. Here's our supraspinatus again. Nice homogeneous low signal intensity. We're going to keep going. Here's supraspinatus. And then once these fibers start to have a more oblique orientation rather than a horizontal orientation, then that's a clue that we're beginning to get into the infraspinatus tendon. And we can see that these are a little bit more obliquely oriented, and they're inserting here on the greater tuberosity and the middle facet. And again, here's that infraspinatus. And we're beginning to see, actually, this is also infraspinatus here, and teres minor. So I'm just going to do that one more time from posterior to inferior now. Teres minor. Here's that more obliquely oriented infraspinatus tendon. I think I was a little bit early on that. Here's more posterior supraspinatus. And then as we course in, anteriorly, here's the more horizontally oriented supraspinatus. And then we're seeing that, you know, the labrum here, there's a superior labrum, there's the posterior superior labrum, and the anterior superior labrum here in this general area. So we'll see a bunch of cases here better depicting some pathology. We can see our acromioclavicular joint. We can see the suprascapular nerve coming here through our suprascapular notch. And then we also have our spinal glenoid notch. And we won't get to this much today, but these notches are important to interrogate, because if there's a labral tear and a paralabral cyst, those cystic structures can come and impinge upon the suprascapular nerve in these regions and cause denervation changes of the rotator cuff musculature, something to keep an eye on. Here's our axillary neurovascular bundle, also coming through our quadrilateral space, which we'll see on some other planes. So here's a sagittal plane now, and this is more fat sensitive, is a T1 weighted sagittal. And you want your sagittal plane, you want to have a T1 weighted sagittal plane image, because a very important thing for us to document is any atrophy of the rotator cuff musculature. And as we know, atrophy can be depicted by fatty infiltration of the musculature or loss of muscle bulk. And if we want to have a fat sensitive sequence to be able to see that. So I'm going to go from here. So we are far from, so this is lateral, this is more medial, and we can see again, similar to our scapular Y view, supraspinatus, infraspinatus, teres minor, and subscapularis. And as we course a little bit more lateral, here's a really good supraspinatus muscle bulk. I like to use this sign we'll talk about later called the tangent line sign. And it's a sign that if you draw a tangent line from the scapular spine to the base of the coracoid process, the supraspinatus should fill up this whole fossa. And if it doesn't, then that is a sign of supraspinatus muscle atrophy, which is a poor prognosticator of, rotator cuff repair. If you were to repair a patient with significant atrophy, they tend to have higher failure rates. So this is a good tangent line sign. We see not a lot of fatty marbleization. I tell residents that you don't want your rotator cuff to look like a Wagyu steak. Generally, you want it to look like a very lean steak without a lot of fatty infiltration. So we're going to come a little bit more laterally now. As we go lateral, we can see again, here's a nice good muscle bulk. Here's our coracoclavicular ligaments, infraspinatus, teres minor. Here's that spinoglenoid notch. We can see that suprascapular nerve coming through that area. And we begin to see the glenoid, subscapularis, coracoid process. And then as I go, I just watch these tendons and I look for their insertions to make sure that they're intact. So we're looking at everything in cross section here. And this is a good look at your horizontally superior facet, your kind of obliquely oriented middle facet. And then as we go a little bit more, it's not well depicted on this case, but here's our vertically oriented inferior facet where our teres minor would insert. The sagittal plane is also really important for the long head of the biceps. So we can see our supraglenoid tubercle here, and we're going to see a structure come off of it right here. This is our long head biceps tendon origin, and we can follow it out right here, and then it's going to eventually come out, and we can see it right here, and coming down here over the intertubercular sulcus. So it's a great plane for a long head biceps tendon. And last but not least, we'll just quickly run through the axial plane. And here's our acromioclavicular joint. This is really good. So this patient is not skeletally mature, so you can see that their acromial apophysis is still open, but it's not uncommon for patients to have an os acromial, which is a persistently unfused acromial apophysis, and there have been some associations of that with shoulder pathology or impingement. So it's an important thing to document if you see it. Here's our nice supraspinatus tendon coming from medial to lateral. We begin to see some of our deltoid musculature. Here's that long head of the biceps tendon, which was originating from our supraglenoid tubercle. Here's our teres minor. Here, inserting more posteriorly, we begin to see the subscapularis tendon insertion. We can see our anterior superior labrum here. Again, anterior superior labrum, posterior superior labrum. And we begin to see the anterior inferior and posterior inferior labrum. And there's various labral variants that we'll discuss later on in the talk. And here is one of them, actually, where we have a sublabral, let me see. This may be a sublabral foramen where we see a little bit of fluid signal intensity undermining the base of the labrum, but it goes away at the level of the equator. So we'll talk about the labrum a little bit, but we need to be able to differentiate labral variants from labral pathology. Okay, so I'll move on here. So here's a question I'm going to pose to you folks. I'll give you a moment to take a look at this axial and coronal images, and you may remember this structure from what we have evaluated on our coronal plane. It's this structures here. And I want you to pay particular attention to this area, And then I want you to pay particular attention to this area as well. Okay, so this is one thing, and then these two things are the same thing. So I'll pose a question to you. Oh, it's not showing up. Okay. So I'm just going to give the answers, I guess. I thought these were going to show up, but all right. So these are both, they're not variants, but they're things that can mimic disease. Okay. So this is our long head of the biceps tendon here. And this is what's called the aponeurotic expansion of our supraspinatus tendon. So the supraspinatus tendon not uncommonly has this expansion of its anterior fibers that go inferiorly and kind of form like a roof of this intertubercular sulcus. It's like a fibrous tissue, and it's called the aponeurotic expansion. And you want to be able to differentiate that from a split tear of the long head biceps tendon, because the split tear is obviously pathologic and an aponeurotic expansion is not pathologic and can mimic disease. And I'll prove it to you here shortly that that's the case. And then here, this is a normal labrum. And this is our middle glenohumeral ligament. And this is another thing that can mimic disease. You don't want to mistake fluid between the middle glenohumeral ligament and the anterior labrum as a labral tear. This is normal pathology, normal anatomy. So I'm going to show these to you on these more dynamic images. So hopefully you remember on the case prior to this, when we were talking about normal anatomy, this is our supraspinatus tendon. And as we go scroll inferiorly, I want you to look at this tendon and I want you to watch some of its anterior fibers right here. Okay, it's going to have a thickened cord-like appearance. It is here now. Here. 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 Now we can separate it from the long head biceps, and this is that aponeurotic expansion of the supraspinatus tendon. So it's not a split tear, it's normal anatomy, and just keep that in mind. Here again is our labrum. So this is a nice sublabral foramen, again, fluid signal intensity undermining the base of the labrum at the anterior superior labrum, which goes away at the level of the equator. We can see here now. And so this is our middle glenohumeral ligament anterior to that, which is just a normal ligamentous structure and is not pathologic. Okay, so that's the axial plane. I want to show you the same thing on the coronal plane. Okay, so I want you to follow this structure. So this is our long head biceps tendon, and I want you to follow this structure as we course posteriorly. Here it is now. And then it joins with the rest of the supraspinatus tendon. It just comes, so I'll go again through it. Now in the other direction, supraspinatus tendon, we're going to go anteriorly. And then this cord-like thickened aponeurotic expansion of the supraspinatus tendon. Again, not pathologic. Here's our long head biceps tendon, and we can watch that nicely going to our superior labrum. So something to be aware of when you want to call a split tear, just make sure that you're not mistaking that for a aponeurotic expansion. And then in addition, if you want to call labral tear, make sure you can identify the middle glenohumeral ligament and differentiate that from a tear. So let's go through some bread and butter cases now that we've got some normal anatomy down. And so here is a nice coronal, fluid sensitive, fat saturated image of the rotator cuff, specifically their supraspinatus tendon here. And we can see, in contrast to the cases we were looking at earlier, that this tendon is heterogeneously thickened and has some increased signal intensity. And just for the sake of comparison, I'd like you to look at this nice homogeneous, relatively homogeneous tendon insertion that's not super thick. I don't have a measurement tool here, but this is a nice normal young patient. And this is an abnormal, thickened heterogeneous tendinosis. So mild or moderate, I think, would be acceptable in this, or moderate would probably be, that's at least what I would do, but you just see enough of them and you'll be able to start differentiating that. So tendinosis, no tear though. So the differentiating tendinosis from tearing is important. Tearing requires generally fluid signal intensity disruption of the tendon. Okay, so we're looking for a tendon that is disrupted by fluid signal intensity and that it's not inserting at its normal footprint. There are some cases that's a little bit more complicated where you really just lose the fibrillar morphology of the tendon, and sometimes you may query the possibility of a tear there, but that takes a lot of, I guess, experience of seeing a lot of them. So here is a normal coronal image, and I want you to keep in mind the footprint. All right, so we talked about this a little bit, that the rotator cuff tendon insertions have a footprint that's generally about 10 to 12 millimeters in length, and then each tendon has a bursal surface closer to the subacromial subdeltoid bursa and an articular surface. And so we want to separate if the tear is from the articular side or the bursal side, or if it's intrasubstance tearing, so that the orthopedic surgeons, when they go to do their surgeries, they can put, it's subjective. There's no measurement that I use for tendinosis, it's just subjective. But you want to be able to tell the surgeon where to put their scopes and look for the tear, whether they should go to the bursal side or the articular surface side. And so there's a grading system for partial thickness tears, whereas less than 3 millimeters is a grade 1, 3 to 6 millimeters is grade 2, and greater than 6 millimeters is grade 3. So if this is 12 millimeters, basically I don't usually, honestly practically use this grading system. I call it whether it's partial thickness or full thickness. And if it's partial thickness, I want to separate that into high grade, which is greater than 50%, or low grade, which is less than 50%. And then you could use moderate grade, which is at 50%-ish, but I don't think that is very helpful. So I try to separate it into high or low grade. But here's our indications for surgery. There's more indications you could check out, but here's some of the major ones: bursal sided tears that are greater than 3 millimeters in thickness, and partial articular surface tears greater than 50%. And that's why I use that 50% more commonly. And acute full thickness tears are indications for surgery. And there are some anterior posterior measurements too that I do not have off the top of my head here. Good question. So may we call it generally tendinopathic, or are there specifications? It's really, up to you and the clinicians that you work for. I generally try to stratify it as mild, moderate, or severe, because it gives the surgeon an indication of what the tendon quality is. So if they go in for surgery on a severely tendinopathic tendon, those tendons, I'm told, are very, for lack of a better term, mushy, or they are difficult to repair because of how poor the tendon quality is. And there are some surgical things that they can do in order to, they can get grafts in order to be able to better repair that tendon and give it a little bit better quality. We're going to look at some tendon tears here, and we'll talk a little bit about how to do these measurements. Okay, so here's a case I'd like you all to take a look at. Here is the sagittal plane, and here's the coronal plane. And just imagine here that this is the leading edge of our supraspinatus tendon. Just give everybody a moment to see what they think. Okay, so on our sagittal plane image, we can see that there's fluid signal intensity at the anterior supraspinatus tendon insertion right here. Okay, so there's definitely a partial thickness tear here, because we can see some of the bursal surface is intact and the articular surface is where the fluid is. And that's corroborated here on our coronal plane, where we see fluid signal intensity at the articular surface and intact bursal surface fibers. This is probably like a moderate to high, this is about 50% of the tendon thickness that's involved, I would say. So maybe this is a, let's say, moderate grade tear articular surface tear of the supraspinatus tendon insertion with intact bursal surface fibers, and there's probably some tendinosis, but I don't see enough of the tendon to be able to identify that. So, and to answer Alex's question, how would we see and measure bursal tear? It would be similar to this, except for the articular surface would then be intact, but the bursal surface, the loss of thickness and the fluid signal would be on the bursal surface rather than the articular surface, as is seen in this case. And on the coronal plane, we wouldn't see fluid signal here on the articular surface. That would be intact, but we would see disruption of the bursal surface fibers. And then, so your measurement of the tendon thickness in, as it is pertains to this image is, so this is the thickness of the tendon. So this is the percentage that we're giving, or the 3 to 6 or 6 millimeters that we're giving is how much of this dimension is disrupted. But you also want to comment on the AP dimension on the sagittal plane. So let's say this is all supraspinatus tendon. We would want to give a measurement that in the AP dimension, this is how much of the tendon is torn, which I don't have calipers here, but let's say 6 millimeters or something like that. Because that also gives the surgeon some idea of how much tendon is involved, and we'll see some more cases to depict that. So yeah, just in general, I want to review. I had a slide on this, I think, that was a question, but unfortunately it's not showing here. Let me just, maybe if I exit, can you still see my slides?
Yes.
Okay, perfect. So let's see how okay, here we go. Here's my question, one of the questions. So which of the following should be documented in an MRI report of a rotator cuff tear? Okay, so the answer here, as you may have guessed, a good test taking strategy is that all of the above. If there's multiple choices and all of the above is a choice, then it's probably going to be all of the above. But so you want to document in your report on the sagittal plane the anteroposterior dimension of the tear, as we saw in this case. For example, like it would be this much. I would measure this much on the sagittal plane and say this much of the tendon is involved. Sometimes the trick you can use is if it doesn't lay out well on the sagittal plane for some reason, but you see it quite nicely, the tear on the coronal plane, if you keep in mind your slice thickness on the coronal plane, you can count a number of slices and multiply it by your slice thickness is something I do sometimes. So if I see it better in the coronal plane, maybe I say, okay, it's 2 slices that I see this tear, and at the 3rd slice it's intact, and my slice thickness is approximately 3 millimeters, so it's probably 6 millimeters in AP dimension. That's another thing you can do. Okay, so yes, so where was that question here? So you want to document the anteroposterior dimension of the tear. You want to document the degree of tendon retraction. Okay, so if we were to go here on this case, the tendon is not really retracted. It's still here at the footprint. But sometimes when there's a full thickness tear, for example, there's nothing holding the tendon back, so it might retract to here, for example. Or so this would all be fluid, and then the tendon is retracted to here or to here. So I like to give landmarks, or you can give a measurement from where the retracted stump is to the footprint. Or I say it's retracted, for example, to the humeral vertex or to the glenohumeral joint. And that degree of tendon retraction is a indicator of the tendon compliance. So that tells the surgeon, okay, this tendon is very retracted. And if I go in and try to repair this surgically, it might be difficult for me to bring it all the way back to the footprint because it's so retracted. And that is another case where maybe they want to use some sort of graft in order to improve the outcome potentially. And that's still, those sort of studies are still they're in progress, but there are various grafts that they can use to kind of help with these full thickness retracted rotator cuff tears. So that's one thing you want to document. The degree of muscle atrophy, which we've kind of already talked about using that tangent line sign. And similar to tendinosis, it just depends on how much fat I see and how much volume loss I see, and I'll give mild, moderate, or severe based on that. The degree of the tendon thickness involved, if we already talked about, from the articular to the bursal surface is about 12 millimeters, and you want to talk about how much of that is involved. And then which surface of the tendon is torn if it's partial, so articular surface or bursal surface. Okay, So we'll go back to our full view here. I want you to, before I do that, take a look at this image. Ideally, you would click on the abnormality, but let's just say, think to yourself, which muscle is the abnormality in, or which muscle or tendon? Is it subscapularis, supraspinatus, infraspinatus, or teres minor? You can chat it in the box if you like, or you could just think to yourself in your head, whatever you want. I've got one for infra. Agree. I agree. So yes, we can see on this plane that there's a little bit of rounded fluid signal intensity. Yes, love it. Thank you so much, everyone, for participating. That there's a rounded fluid signal intensity in the infraspinatus, muscle here, and we'll see what that is here shortly. Okay, so here's that same case. There's that rounded fluid signal intensity, and now we can see that it's kind of, along the myotendinous junction, and I want to prove to you that that's like a sentinel cyst sign. So similar to a paralabral cyst being a sign of a labral tear, or a parameniscal cyst being a sign of a meniscal tear, these sentinel cysts can be a sign of tendon tearing. And we can see, let's find the cyst first and work backwards. So here's our cyst right here. And we're going to work backwards and try to track it. So I see it from here, fluid, a little bit of fluid there, here, and a little thin stripe there, and then there. So it can be from articular surface tearing, it can be from intrasubstance tearing, more commonly in this case, where the bursal surface is intact and the articular surface is intact, but there's some intrasubstance tearing at the footprint here that allows for this like fluid to form or track along the myotendinous junction. This is a great example of a intrasubstance tear where the bursal surface is intact, the articular surface is intact, but in the middle we see some tearing and fluid signal intensity allowing for this cyst to track along the myotendinous junction. And so when you see something like that, go find yourself a tear. Okay, I'm going to leave here so you can see this question again. So here is a case that I'd like you to click on the retracted tendon stump, but since we can't do that, I'd like to show you that it's right here. Obviously, we can see fluid signal. We don't see any tendon in this general area, but we see it right here, retracted to the level of the glenohumeral joint. And this slide shows it a little bit more nicely. How am I doing on time? Okay, I'm going to go a little bit faster. And so this is a full thickness tear of the supraspinatus tendon, which is retracted to the level of the glenohumeral joint. A couple other things I want to point out here, that this is a chronic tear, because we can see now that the undersurface, okay, thank you, of the acromion is scalloped. There's some scalloping of the acromial undersurface here, and that's called acetabularization of the acromion. And it's an indicator of chronic rotator cuff tearing, because when you get a full thickness rotator cuff tear, always on radiographs, keep in mind your acromiohumeral interval. And you can radiopedia it, I don't know off the top of my head, but there's a normal number, and I think less than 7 is an indicator of tendon thinning. And so the higher your humeral head is riding on an AP radiograph, the more likely it is that you have a full thickness rotator cuff tear. And here's a direct example where, we have a high riding humeral head and it's chronically scalloping the acromial undersurface. And this is known as acetabularization of the acromion. And another finding here of full thickness chronic tearing is that we've kind of lost the normal morphology of our footprint. So usually you have our articular surface, there's a little bit of gap, and then there's a shelf that forms here. And this shelf is where our footprint of our rotator cuff tendons are. And we can see now it's just perfectly rounded. There's no shelf there anymore. And that's because this has just been eroded over time with repeated abduction against the acromion, kind of eroding that normal morphology. Another sign here of a full thickness tear is our cyst, cyst superficial to the deltoid musculature. And it's not uncommon in the setting of full thickness rotator cuff tears for fluid in this bursa here, the subacromial subdeltoid bursa, to insinuate into the acromioclavicular joint, disrupt its capsule, and then form a cyst in the subcutaneous soft tissues. And it's not uncommon for patients to present with a palpable mass there. Think it's something concerning, but really it's just probably a cyst that's emanating from the acromioclavicular joint. So here's some examples of muscle atrophy. And we can see here that there's pretty marked atrophy. You know, this is not filling our supraspinatus fossa, this supraspinatus muscle. And the infraspinatus is also a little bit marbleized relative to the teres minor and subscap. So there's probably some moderate to severe atrophy here of the rotator cuff, supraspinatus, and infraspinatus. And there's some various stagings we can use. Goutallier is one of the stagings. And this is stratified by how much fat you see relative to muscle. Okay, so 0, 1, 2, 3, or 4, and there's various orthopedic studies that quantify they stratify the patient's post-surgical outcomes relative to their Goutallier stage. But I'm a simple person and I don't want to think too hard, so I prefer, and here's here's a good radiographics article by Morag et al. Showing what the clinician needs to know on MR imaging of the rotator cuff. But I like this tangent line sign, just in how much of this fossa does the supraspinatus fill. And we can see here it's nice and full. Here, in contrast, it's not filling that fossa and is therefore atrophic. So as it pertains to the rotator cuff tear chronicity, as I've alluded to already, the degree of muscle atrophy can impact surgical outcomes with chronic tears. And if the cross-sectional area is less than 50% of this fossa on the sagittal oblique plane, this indicates supraspinatus atrophy, significant atrophy, which was shown to correlate with recurrence of tear after a surgical repair. So generally, it's it's a relative contraindication to surgery, I guess, or just a poor prognostic indicator. So external impingement, as I've alluded to already, this is a great example of it, where we see some acromioclavicular arthrosis, and we can see these productive changes at the undersurface of the acromion. And we can see perfectly on the MRI, quite nicely actually, that the supraspinatus myotendinous junction is this downward bowing in this region because it's being impinged upon by the acromioclavicular arthrosis. Something to keep in mind on x-rays. And I say on x-rays, for example, I mean, I say downward sloping acromioclavicular osteophytes, which may be seen in the setting of external impingement. Anytime we're talking about a syndrome, it's important to know, that we are seeing imaging manifestations. It does not mean that it's present in this patient. This is a great question. So do I report the types of acromion? I personally do not. There are people in my practice that do report whether it's a type 1, 2, or 3, and unfortunately I don't have any slides on that today. But there are people in my practice who do. I just report if there's a lateral acromial downsloping or not, but there are some that do report the types of acromion. And we can see the sagittal plane is also very nice for this external impingement. And usually there's a nice fat plane beneath the acromioclavicular joint and superficial to the supraspinatus myotendinous junction. And if I don't see that fat plane, that is something I report, that there's absence of the fat plane beneath the acromioclavicular joint, and the constellation of those findings may be seen in the setting of subacromial or external impingement in the appropriate clinical scenario. Okay, let's see what my question is here. Okay, so here's the question. All of the following are variants of the glenoid labrum except Bankart, Beaufort, a sulcus or a recess, a foramen, or all of the above are variants. Correct. Yeah, this is a pretty easy one. So the Bankart is obviously a pathology of the labrum or the glenoid, whereas Beaufort, sulcus, foramen are all variants of the labrum. And so there was a question: do I report types of capsule insertion? I generally do not report, or I have not reported a type of a capsule insertion in my experience, if I'm understanding correctly. And a lot of this, varies based on your clinicians. If that's something that your clinicians ask you commonly and they want you to report on, then it's something you could, modify your practice to do. I've never been asked to do so, so I do not typically do that. But if it was something that our new clinicians, for example, came in and wanted to know, then it's something I would start incorporating into my practice, because we are physicians, so to speak. So I see a hand raised. Do you have a question, Santosh?
I believe it was my mistake. Go ahead.
Okay, no worries. All right, I'm gonna move on here. Sameh, I see your question. Role of ultrasound in the rotator cuff. There is a good role for ultrasound in the rotator cuff, and it's very commonly performed in Canada and some European countries, and is being more and more commonly performed in the United States. You can see rotator cuff tears. You can document if it's partial or full thickness. Our surgeons here really prefer MRI because they don't really, it's easier for them to make sense of it. And, you get the information about muscle atrophy, you get information about, the biceps and things like that, at least the intra-articular portions. So, we do some ultrasound, but generally if you see something on ultrasound that requires an MRI, you still end up getting an MRI. So we end up doing more MRI than ultrasound, but I've been to various conferences and stuff, and it seems like it is very commonly used in some other areas, but at least in our clinical practices in Cleveland, Ohio, we're doing more and more of it, but it's not as common as MR. So here's a sagittal plane image. I wanted to show you folks, that we can see that the glenoid labrum here a little bit, and I wanted to show you on a sagittal plane image is a great plane for the superior, middle, and inferior glenohumeral ligaments. Inferior glenohumeral ligament has posterior and anterior bands, and a really important thing to know is that the anterior band of the inferior glenohumeral ligament inserts partially on the antero-inferior labrum, or attaches, I should say, and the glenohumeral ligaments are very important passive stabilizers of the shoulder, or the glenohumeral joint, I should say. And so that is why these labral tears, particularly in the antero-inferior regions, can result in instability of the glenohumeral joint, and these patients tend to have recurrent dislocations, partially because of the labral tear, but partially because that those glenohumeral ligament, especially the inferior one, originates or attaches to the antero-inferior labrum in part. So something to keep in mind. I have an image here, an arthrogram, and we can see nicely on this. Oh, if I can get it to pause, okay. So this is a T1 weighted fat saturated intra-articular gadolinium, and we can see here our inferior glenohumeral ligament and its intimate association with that anterior labrum. We see nicely our middle glenohumeral ligament here, and the superior glenohumeral ligament is here. Not well seen in this image, but just keep that in mind. We also see nicely our long head biceps coming out of the glenohumeral joint and down inferiorly here. So sagittal plane, again, very nice for the long head biceps tendon. Okay, so here is a case. So which one of those variants do you folks think this is? Is this a foramen? Is this a Buford? Is this a sulcus? I'll just give you, I know it's not a lot of images. This is below the equator, below the midline, I would say. This is above the midline. Yep, exactly. So here's our posterior superior labrum. Here's our posterior inferior labrum. Here's our anterior inferior labrum. Our anterior superior labrum is absent. We don't even see it here. It's an absent anterior superior labrum, and we have a relatively thickened cord-like Buford. thickened cord-like middle glenohumeral ligament, I should say. And those findings in combination are consistent with the Buford complex. And that should go away again below the 3 o'clock position or below the midline and reattach. So an absent anterior superior labrum and a thickened cord-like middle glenohumeral ligament with a normal anterior inferior labrum, that is known as a Buford complex and is not pathologic. And in the States, we have this sandwich from this place, this Checkers is a restaurant, fast food restaurant. This is known as the Big Buford. And, you know, in America, we do everything extra. So just one patty is not enough. We need 2 patties. We need 2 layers of cheese. So this is called the Big Buford. And it's a indicator of just a silly thing to remember, the Buford complex. So here's a case. I'll do it again just so you can see one more time. And we're going to pay attention to the labrum particularly on this. Okay, so we're at the anterior superior aspect here. We see this structure and we see some fluid signal intensity under it. And as we continue to scroll down, I don't know about you folks, but I get the sense that this is 2 different structures. Here's our anterior labrum. Here's our middle glenohumeral ligament, and there's some signal in between them. And so I think we have, so recess is close, very close. This is a different than a recess, but very close. I'm going to keep going. And then as we go inferiorly, that it reattaches. So this fluid or this contrast goes, let's say, from the 12 to the 3 o'clock position. So this is actually a variant. This is a sublabral foramen. Okay, so a sublabral foramen, exactly, Mona, well done. A sublabral foramen is where there's fluid or contrast that undermines the superior labrum and extends to, you know, it only goes from 12 to 3. If we were looking at the labrum and as a clock face from the side, it will never extend below, again, none of these variants extend below the 3 o'clock or the midline. And there's just thinly marginated, and it's very like homogeneous. There's no heterogeneity, there's no fraying there. This is very smooth. And so this is a sublabral foramen with a intact, there's just adjacent middle glenohumeral ligament. A sublabral sulcus would look exactly like this, except for we would only see it at the superior labrum. A sublabral recess or a sulcus is generally at the 12 o'clock position or 11, 12, 10 maybe, but it should never, it generally doesn't go anteriorly like that. So arthrograms, yes, I mean, there are some studies, at least for the hip, the labrum and the hip, that suggest that 3T non-arthrogram, a 3 Tesla non-arthrogram, is at least non-inferior to a 1.5 T arthrogram. I forget if it was the hip or shoulder. There was definitely did it in one. And so, you know, it just depends, I guess, on the patient. But in general, I would say, yes, arthrographic technique is ideal. But there are some studies that suggest a non-arthrographic 3 Tesla is non-inferior. But in this case, yeah, I mean, this is definitely just a variant. It's very smooth. That smoothness is a key, that this is normal. If it was a little bit more irregular there, you know, then maybe it would be pathologic, but we'll see. So here's another example from the literature. This is an arthrogram, again, smoothly marginated. And again, this is that anterior superior labrum, that's the middle glenohumeral ligament, and this is a foramen. And I'm going to give you some criteria here. So again, this is where they occur. So when I say the equator, I'm talking about here. This is 3 o'clock. This is 9 o'clock, 12 o'clock. I'm sorry, 12 o'clock, 6 o'clock. And all the variants tend to occur like from here to here. Nothing generally below that area. Here's that sublabral sulcus that somebody had mentioned, pretty smoothly marginated, contrast signal intensity, no irregularity, and it doesn't extend anteriorly or posteriorly, and there's cartilage undermining it. It's a nice example of a sublabral foramen. I mean, sublabral sulcus or recess. Question? Okay. I'm sorry, it was really choppy on my end if there was a question.
I think it was by mistake.
Okay, no worries. Moving on. Here is another. Okay, so now we've talked about some normal anatomy. We can get into some pathology. So here's a nice case. Yeah, the difference between a sulcus and a foramen is that a sulcus is only involving the superior labrum, and a foramen involves the superior and anterior superior labrum. That's the only difference. And the way I remember that is a foramen goes forward, whereas a sulcus doesn't have forward in the word. So yes, we see a nice Hill-Sachs impaction deformity. And there is a Bankart, so we have a soft tissue Bankart here. There's a specific name for this type of labral tear, though, because we can see that the periosteum is a little bit elevated here. And we can actually see that there's some cartilage loss here, too. So there's a few different, yes, exactly, Yasser, well done. This is a Perthes lesion, and that's different from an ALPSA, which we'll talk about, an anterior labral periosteal sleeve avulsion. So a Perthes is just that the periosteum is elevated, but the labrum is still attached. It's not detached, it's not medialized. And you could even call this a GLAD if you wanted to, which is a glenoid labral articular cartilage disruption, because we can see nice intermediate articular cartilage signal intensity here. And here we see an articular cartilage defect. I mean, it doesn't really matter what you call it, honestly, as long as you say that there's an anterior labral tearing with elevation of the periosteum and adjacent articular cartilage defect. I think everybody's happy. But this is generally would be a Perthes with a GLAD potentially. And then, so what do you folks think about this case? I really like the T1s here. Is this all soft tissue pathology, or is there also bony pathology? Yes, exactly. So I have May that tells me there's a bony Bankart or osseous Bankart, Iman, Rasha, Asma, Yasser, thank you everyone. Yes, so this is a nice example. So the glenoid should be shaped like a pear, right? I mean, let me show you, boom, here's our pear. And we can see here that we have glenoid, here's our supraglenoid, tubercle, glenoid, 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 but it's not round here because there's a defect. And here is our osseous Bankart that's displaced anteriorly. So the sagittal plane is a great plane to measure this osseous Bankart. I would say that there's a bony Bankart involving the anterior glenoid that measures this much by this much by this much by this much, because the degree of bone loss is a measure by which they use to decide if they should do a Latarjet procedure or some sort of procedure where they take the coracoid process, do an osteotomy, and they can rebuild the anterior glenoid using the coracoid process. So that's something I like to do on the sagittal plane, is measure my bony Bankart. Here on the axial, we can see that there's some marrow edema, and that's our bony fragment here with some glenoid fragmentation. And this is kind of what it would look like here if it was a pear. And just only a few more slides left, 10 more, so we're getting there. But so the glenoid labrum, when we're talking about the locations, we separate it into these hex stents. So we have our superior, anterior, superior, anterior, inferior, inferior, posterior, inferior, and posterior, superior. and that's how we separate it into zones anatomically, and it should be low signal on all pulse sequences. And so to diagnose labral tear, so here's some of those things I wanted to talk about where we want to differentiate tear versus normal anatomy or variance. So if the signal intensity is within the labrum as opposed to undermining it, it is more likely to be pathologic. If the margins are irregular, it is more likely to be pathologic. If the signal intensity extends posterior to the origin of the long head biceps tendon, it's more likely to be pathologic. If the signal intensity extends below the 3 o'clock position, it's more likely to be pathologic. If the width of that fluid signal intensity that's undermining the labrum is greater than 2 in a non-arthrogram or 2.5 millimeters in an arthrogram, it's more likely to be pathologic. And if there's a paralabral cyst, it suggests pathology. So these are some criteria to keep in mind when we're differentiating tear versus variant. So here's one more, tear versus variant. We can see that signal intensity here is within the substance of the labrum. It's going into the labrum, not away from the labrum. So that's pathology. And we can see that this anterior labrum is macerated and displaced medially. That is pathology. Here we see a paralabral cyst in the suprascapular notch here, or in the spinal glenoid notch, I should say. And that is obviously indication of a labral tear, which now we see right here as this fluid signal intensity extending towards this paralabral cyst. It's not mandatory to do an arthrogram, but it will increase your sensitivity and specificity. Somebody's asking, but a non-arthrographic, if you're going to do a non-arthrogram, I would do a 3 Tesla if you have the option to do so. If there is no option, then arthrogram is recommended. And here we are. So a cyst in this location can impinge upon the suprascapular nerve. So here's the location. So the spinal glenoid notch. So where would we expect there to be denervation? Which muscles? Supra, infra, subscap, or A and B? So in this case, yeah, it's just infraspinatus. So the spinal glenoid notch is more distal, whereas the suprascapular notch is more proximal. So by the time the cyst is in the spinal glenoid notch, the supraspinatus has already been innervated. So we would only see infraspinatus, edema, and maybe some atrophy, as we can see in this case. And then approaching the end here, we talked about a Perthes. Here is an example of an ALPSA. We see our Hill-Sachs impaction deformity, and now we can see the anterior labrum, instead of being over here in its normal anatomic location, it's medialized with some scarring. And here is a Perthes or ALPSA, anterior labral periosteal sleeve avulsion. Okay, I'm going to repeat this denervation pattern again. So this is the spinal glenoid notch. And then there's a notch, the suprascapular notch, that's a little bit more anterior. And so the suprascapular nerve, it's the same nerve in the suprascapular notch and the spinal glenoid notch. At the level of the suprascapular notch, which is not in this image, the supraspinatus and the infraspinatus, neither has been innervated yet. So if you see a paralabral cyst in the suprascapular notch, then look for denervation of supraspinatus and infraspinatus. In this location, this is distal to the suprascapular notch. So the supraspinatus has already been innervated here by the suprascapular nerve, and therefore we're impinging on the suprascapular nerve distal to the supraspinatus innervation. So this would only affect the infraspinatus, and that's why we see that here in the normal supraspinatus. Again, so here's the ALPSA, and I'll show Rana at the very end. I'm going to go just to the coronals in the very beginning, and we'll show the anatomy of the different notches. This is our ALPSA we talked about. This is that Perthes again, and just to show them side by side, medialized and not medialized. But the periosteum is still elevated in both. So here are some of my references, and just really quickly, just to answer the anatomy question about those notches, I'll just run through this real quickly. So here we are on the coronal plane, coracoid process, subscap, we're getting to where, all right, so here in this area, this is our suprascapular notch. Here, and then we're going more posteriorly now, and now we see the glenoid and the beginning of the spine of the scapula. This is our spinal glenoid notch. Okay, so that's they're not far from each other, but you know, they have different. So let's see here again on the coronal, on the sagittal plane. So here's our spinal glenoid notch here. And I don't think I have a good sagittal image to show the suprascapular notch on this one, unfortunately. But let's try on the axials, it's a little bit easier. So again, here is the axial plane imaging, supraspinatus. Okay, so here, suprascapular notch, and then spinal glenoid notch is here. Okay, so they're not far from each other. I'll share my email in here. It's navid.faraji@uhhospitals.org. And then if you want to follow me on Twitter, if you'd like, I share some cases, relatively some educational material. It's @sportsraddoc. And then this is our department's Twitter @UH Radiology. So I appreciate everyone's attention. Thank you. Sorry for going over a little bit, but I hope you enjoyed it. Hope it was useful for you.
Thank you so much, Dr. Faraji, for this very informative lecture. And hopefully we look forward to having you with us again next year for more lectures.
Of course, would be happy to do it.
Thank you for your time.
All right. Take care.
Thank you. Have a wonderful day. Thank you. All right, so our next speaker is Islam. Islam, you can start if you want.
Okay, so شكرا Dr. Jim, شكرا Ahmed. Before starting, I want to ask a question. Is everybody speak Arabic or no? Okay, so I believe we have some people who don't speak Arabic. So I think I'll give the lecture in English. Oh, so. Okay, so I think we have some people who don't speak Arabic. So I think I'll give the lecture in English. Okay, so I'm going to share my screen now. I didn't share my screen before, so I think I need to set up something to share it. So 1 second, please. Ahmed, can you hear me?
Yes, let me find the share screen button.
Yes, I think I need to set up something in the settings to be able to set it. So let's give me 1 minute, okay? Maybe I'll go out and come back again.
Okay.
So. احمد انا شايف ده بس انا مش عارف اعمل شير سكرين من الكمبيوتر. Just give me 1 minute, okay? So
Okay.
okay. I will set you as as the main host, okay?
I can change the settings. Can you try right now? I've changed some of the settings. Try sharing right now. We apologize for this delay. We're just trying to fix this technical issue and then we'll start the lecture.
انا عارف بيعمل شير سكرين منين. المشكله في الكمبيوتر، مش المشكله في مش في البتاع. مش انا عارف المشكله في الكمبيوتر، انا بحاول اهو.
It's working now. Islam, I think you need to unmute yourself, but the screen is working.
Can you guys see my screen?
Yeah, it's showing and we can hear, but you can start now.
Okay, cool. So thank you so much for everyone. Thank you, Dr. Sheikh, for allowing me to present today. So today, my name is Islam. I'm working as a radiology department at Bنها University. And today I'm going to talk about, okay. So today I'll talk about some renal pathology, Pearls and pitfalls, okay? And at the end of this lecture, you should able to know some classic signs that allow you to understand where does this lesion originate from. Maybe it's originating from the kidney, from something around the kidney. And you should be able to differentiate between enhancement and pseudo enhancement and what's the clinical significance of pseudo enhancement in patient follow-up. You can know what's the difference between different renal neoplasm and renal pathology are not only clear renal cell carcinoma. And you can know what is a different TNM staging of renal cell carcinoma. And I will give you some common syndromes that are related to renal pathology. So my first slide will be basic principle, how to, so here you can differentiate between acute angle, right angle, and obtuse angle. So I think I created Bool. Let me check if I can initiate it. So, can you guys see the whole screen? So my first
Yes,
slide will
it's
be
showing,
classic
yes.
sign. Okay, so can you please answer which one is arising from the kidney, A or B or C, or A plus B or A plus B plus C? So we have some answer A, some answer B, and some answer C, some answer, and I'll end the Bool now. So, okay, so I think most of the answers pick up the correct answer. So here's the classic sign. Okay, so my first classic sign will help you to differentiate between lesion arising from the kidney and which lesions are arising from outside the kidney. And it's called the cloud sign. And the cloud sign is useful to help to differentiate between lesions that are arising from solid organs. And if you have a lesions that have acute angle with the kidney, that's called to refer to a positive cloud sign. And this lesion will be intrinsic mass and will arising from inside the kidney. And if you have mass with negative cloud sign, this lesion will not have acute or sharp angles with the kidney. So this lesion will be arising from outside the kidney. This is very helpful to differentiate between intrarenal lesions that are like acute angiomyolipoma or retroperitoneal liposarcoma and adrenal myolipoma. So To differentiate between them, renal angiomyolipoma is arising from the kidney, will have positive Clow sign. And as you know, angiomyolipoma is like vascular lesions and will have large vessel. Retroperitoneal liposarcoma will be negative Clow sign, and liposarcoma is usually poor vascular lesions, will not have big vessel like angiomyolipoma. Adrenal myolipoma will be like the visceral fat and will be fatty lesions with negative Clow sign. So our first one would be A. So A will positive Clow sign. This lesion has positive Clow sign, acute angles on both sides of the lesion, and this lesion arising from the kidney, and this lesion was angiomyolipoma. The other two lesions that have negative Clow sign will be, the first one on the left side of the screen will be retroperitoneal liposarcoma. This lesion is not arising from the kidney. It has negative Clow sign. The one on the right side of the screen will be adrenal myolipoma, which is not arising from the kidney. It's arising from adrenal glands, so it has negative Clow sign. Next question will be another classic sign will be how to differentiate between benign lesion or malignant lesion. I will give you some moment to think about it. Which one is benign, which one is malignant? Can you guys see the ball on screen? All right, so I will end the poll now. So most of you guys pick up A is benign lesion and B is malignant lesion. Let's see the result. So the second classic sign will be angular interface sign. Angular interface sign will be to how to differentiate between benign lesion and malignant lesion. Okay, so angular interface sign can help you to differentiate between two exophytic lesions. When you have two small lesions arising from the kidney parenchyma, and one of them will have angular interface sign and the other one will have rounded interface sign. The ones that has angular interface sign will be benign, and the one with rounded interface sign will be malignant. Okay, so the overall performance of this lesion will be a specificity 100%, positive predictive value 100%, negative predictive value is 70%. So every single lesion will angular interface sign will be benign, and if you have a lesion with rounded interface sign, let's talk about it in the next slide. Okay, so A was malignant actually, and B was benign. So the first lesion on the left side of the screen has rounded interface sign with the kidney, and the second one has angular interface sign with the kidney. So this lesion, the lesion on the left side of the screen with rounded interface sign with the kidney on post surgically was proven to be RCC, and the lesion on the right side of the screen after surgery was proven to be angiomyolipoma. And I think you can see like a large vessel, and this lesion has something like cone ice cream arising from the kidney. Okay, so classic sign angular interface sign is every single lesion with round interface sign with the kidney will be benign. The answer is still, unfortunately, will be no, because you still have some lesions that have rounded interface sign with the kidney, but still have benign nature. So this lesion on left kidney is actually oncocytoma, and oncocytoma is a benign lesion. This lesion has rounded interface sign, not angular interface sign, so it's still benign, but not having angular interface sign. So if you see lesion with angular interface sign, it is benign lesion. If you see lesion with round interface sign, you need to think about it. If it is benign or malignant, most likely it will be malignant if it's not oncocytoma. I'm going to initiate the next poll question. Will be poll 3. So the question is, which one is renal infarction of these lesions? All right, so most of you guys pick up A as renal infarction. So let's see what is the answer. So all of them are renal infarction. A, B, C was renal infarction. So cortical rim sign actually when you have it to help to differentiate between acute pyelonephritis and segmental renal infarction. When you have segmental renal infarction, you are complete occluded, like you are stopping the blood to reaching the kidney. But since like you have capsular branches, and the capsular branch that supplies the renal capsule is arising very early from the renal artery. So when you have thrombosis or anything with the renal artery for anything, so you will still have the blood supply coming to the capsule. So you will have cortical rim sign, okay? But when you have acute pyelonephritis, you have combination between ischemia and edema. So once you have edematous parenchyma, you will have edematous capsule, so you will not see the cortical rim sign, okay? So unfortunately, this sign is only present in 50% of the cases. So if you can see this lesion, we have negative or positive. The one on the left side of the screen is negative, so you don't have cortical rim sign. But you have some signs that help you to identify pyelonephritis. This kidney is surrounding by some fat stranding, and if you ask about the clinical scenario of this patient, it might have some after urine analysis, you will have some clue for renal infections and fever. So this patient was pyelonephritis with negative cortical rim sign. The one on right side of the screen, you can see a positive cortical rim sign, and this lesion was segmental ischemia of the kidney. All right, so the next one will be classic. The classic sign is reverse rim sign. The hypo is affecting sign. So this is opposite, completely opposite from the cortical rim sign. You will have some area in the middle of the kidney and area of the cortex. The cortex is hypo. Although the cortex in the nephrographic phase of the kidney should be enhancing, it's not enhancing here. So this is called reverse rim sign. It is very helpful for some scenarios like renal cortical necrosis. Renal cortical necrosis occur with the following: renal transplant rejection, intravascular hemolysis, shock, and as an obstetric complication. So the affecting area is the cortex here, not the medulla. Okay, so here another sign that help you to differentiate between lymphadenopathy and retroperitoneal fibrosis. Retroperitoneal fibrosis, usually the patient will have something with both ureters, and both ureters will have hydroureteral nephrosis, maybe bilateral, maybe in most cases will be bilateral. And sometimes you have lymphoma, and lymphoma may mimic the retroperitoneal fibrosis, and you can use this sign to differentiate between them, and it's called aorta floating sign. If there is a distance between the aorta and the vertebrae increased, you might have aorta, you might have lymphadenopathy, because lymphadenopathy in lymphoma is soft. It's not affecting the diameter of the artery, is not affecting, is not tethering or not like causing any fibrosis around it. So it increases the distance. But if you have a distance decrease between the aorta and the vertebrae, it is more likely to be retroperitoneal fibrosis. All right, so next one, we will talk about renal lesions. We will talk about how and where when we can see the hypervascular lesion, hypovascular lesion, urothelial lesion, and small bowel lesion, when and how. Okay, so this is the renal protocol in CT and MRI. Let's talk about the CT very quickly. So you have an enhancing lesion before the contrast injection, and after the contrast injection, you will have three phases: corticomedullary phase, and the nephrographic phase, and excretory phase. If you would like to see hypervascular lesion, I think it is better to see in the corticomedullary phase. If you are looking for hypovascular lesion, it is better to be appreciated in the nephrographic phase. And if you are looking for transitional cell tumors or lesions with the renal pelvis or the ureter, it is better to think about to see it in urothelial lesions. If you have a small bowel lesion, or you have something not exophytic from the kidney, I think it's better to have the coronary reconstructions so you can be able to appreciate the lesion. Okay, so Here we have the different phases of renal protocol. You have non-contrast, you have corticomedullary phase, which is after 40 seconds of injection of the contrast. You have nephrographic phase, 95 seconds after injection of the contrast, and excretory phase usually between 3 and 15 minutes. And sometime, like the large interval of the excretory phase, it depends on the function of the kidney. Sometimes you have the patient with some like poor excretory function of both kidneys. So you have to ask the patient to come back again after 15 minutes because you would like to see the contrast is excretory and you in the renal pelvis and the ureter. So this is make it like between 3 and 15 minutes. It depends on the difference between different patient and excretion of the contrast from the kidney. Okay, so here is very good algorithm. You guys should depend on it on diagnosing of any renal lesions. If you have solid renal cortical mass, you have to think about excluding pseudomass. Okay, let's exclude the pseudomasses first. Okay, so the first one on the top of left side of the screen, you have hump. And the hump is usually more appreciated on the left kidney, and you will have something in the interpolar zone, which is look like the parenchyma, but it is making hump. If you mix the vascularity, it will be most likely similar to the around parenchyma. And here we have corticomedullary phase of the kidney, which is look like normal parenchyma, so it's not lesion, it is just like pseudo tumor. The second one will be hypertrophied column of Burton, which will be invagination of the renal parenchyma into sinus fat. And if you scan this patient using the contrast in the corticomedullary phase, you'll still see a normal parenchyma with no any suspicious or conspicuous lesion. The third pseudo tumor will be persistent fetal lupulation, and persistent fetal lupulation, it will be something that's maybe it's mimic mimic renal fibrosis or something any with the renal chronic pyelonephritis. So you need to look if the underlying parenchyma, if the thickness of the underlying parenchyma is normal, that's more likely to be persistent fetal lupulation. Let's go back. After exclusion of the pseudo tumor, we need to think about the true mass. Okay, if your mass has macroscopic fat, it is more likely to be angiomyolipoma. It is very rare to be a renal cell carcinoma, and I will talk about this later, because like it is unlikely to have macroscopic fat in renal cell carcinoma without calcifications. I will talk about that later. So the enhancing soft tissue density. So if you have soft tissue mass inside the kidney, it is enhancing. It is more likely to be clear renal cell carcinoma. Okay, if it's not, if it is rare scenario will be benign or malignant different lesions, and the malignant rare lesion will be metastatic lesions, lymphoma and leukemia. If it is benign, it will be oncocytoma, or maybe minimal fat-containing angiomyolipoma or metanephric adenoma, and I'll talk about this later. Okay, so please Doppler every single cyst. Here we have a lesion renal mass evaluation. So simple cyst usually it is an echoic lesion. It is increased through transmission. So you have acoustic enhancement because it's not just a fluid, and you will have thin imperceptible or no internal vascularity flow. So this was like, if you are scanning this patient very quickly, I think you can like interpret this lesion as a simple cyst. But if you put the color on this lesion, you can see color flow inside. It might be mimicking like AV malformation or AV fistula. So I think it's not gonna like hurt you to put like vascular to check the Doppler of every single mass inside the kidney, especially in ultrasound. So no enhancement. Okay, so here we would like to differentiate between 3 different entity and enhancement. So the first lesion will be if the difference between non-contrast and the contrast is less than 10 Hounsfield units, that's mean no enhancement. If it's a difference between 10 and less than 20, this is a gray zone, what's called the pseudo enhancement. And we will talk about how to resolve this later. And if you have the difference between them, that's like more than 20 Hounsfield unit, that's more like this is definitely enhancement. So here we have a lesion in the kidney, in the right kidney. So this lesion was simple cyst before it has the fluid attenuation with is 9 Hounsfield unit. After injection of the contrast, you have the difference between the Hounsfield unit, which was like 3. So if you look at your reference, this is not enhancement. So you can confident report this as simple cyst. Okay, simple cyst, do not underestimate the CSF signal. If you look at the CS signal, and the simple cyst usually follows the CSF signal in all sequences. If you look at T1 and T1 post contrast and T2, it is hyper intense in T2, it is hypo intense in T1, look like a CSF, and in CT it is density of 9, so it is simple cyst. No enhancement. Okay, so here we have a lesion, this lesion CT. So we scanned this patient with non-contrast, contrast enhancement, nephrographic phase. And lesion typically most conspicuous in this phase, on the nephrographic phase. If it's not enhancing, if it's hypovascular lesion, you should look in the nephrographic phase. And this lesion before contrast, it was 51 Hounsfield unit. It is more likely to be peritoneous content or hemorrhagic content. And if you look in the contrast, the difference between them was 4. Okay, so this is typically, if you look in less than 10, this is not enhancement. So there is no enhancement here. So this is more likely to be benign hemorrhagic cyst. So subtraction for T1 bright lesions. This is very helpful if you are having lesions that is on T1 pre-contrast, which is hyper intense lesion in T1. It is more likely to be peritoneous content or hemorrhagic content. So homogeneous lesion on T1, if it's hyper intense, it is maybe you will miss any enhancement on T1 post contrast. So if you look at this T1 post contrast, maybe you cannot appreciate if this lesion has contrast or no. If you look in T2, this lesion like maybe the signal is like lower than T1, but if you do subtraction, it is really helpful to do subtraction for every single T1 lesion that is hyper intense. So for hemorrhagic peritoneous cyst, if you are suspicious about lesion, if the lesion has T1 hyper intensity, so if you do subtraction, you can be confident, say this lesion has enhancement or no. So subtraction, the post contrast from the pre-contrast image is extremely helpful in evaluation lesions that is bright on T1. And here in this lesion, you can see this lesion was hyper intense in T1. In the gadolinium post contrast, I cannot say if this lesion has enhancement or no. But if you look at the subtraction, you can confidently say there is no any enhancement here. So this is peritoneous or hemorrhagic cyst. Okay, so enhancement is robust enhancement. Okay, so clear renal cell carcinoma is robust enhancement. So any soft tissue lesions in the kidney was robust enhancement, and you look like the top of your differential diagnosis should be the clear renal cell carcinoma. Okay, so we have here a lesion in right kidney, and this lesion Hounsfield unit before injection of the contrast was 23, and after contrast injection, this lesion was 171. Okay, so the difference was 148. So this lesion, of course, has some enhancement, and the enhancement is robust. So your top differential diagnosis should be clear renal cell carcinoma. Okay, pseudo enhancement is not dual energy CT or MRI problem. It is a conventional CT problem. Okay, so what is the meaning of pseudo enhancement? So if you have lesion in the pre-contrast, and this lesion was like a certain Hounsfield unit, and after you inject the contrast, the difference between them was between 10 and 20. So the difference here in this lesion was 15 Hounsfield units. This lesion make enhancement, and also this is still questionable in CT. And here we pseudo enhancement is not a problem in MRI. Why? Because you have subtraction, and subtraction here is very important in two lesions. And one of the lesions that has pseudo enhancement in CT, and the second lesion is hyper intense lesion on T1. And if we have here a lesion on T1 and in post contrast, I'm not sure if this is still the same lesion. And in T2, this lesion is hypo intense in T2. But if you do subtraction for this lesion, you can see there is no any enhancement of this lesion. Okay, so subtraction can solve the problem of pseudo enhancement of CT. For hyperattenuating cyst on CT again, if the patient cannot get iodine contrast or gadolinium, ultrasound should be considered for this lesion, and you should scan the patient with Doppler to see if this lesion has any abnormal or any soft tissue component. Okay, so pseudo enhancement is not a problem in MRI because you have subtraction, and you can see if this lesion is enhancing or not. Okay, so renal cell carcinoma are likely to be that high density. Okay, so here we have a lesion which is in pre-contrast, the Hounsfield unit is 93. It is unlikely to see renal cell carcinoma with this very high density. Okay, so let's say we have homogeneous lesion, non-contrast lesion with Hounsfield unit greater than 70. Hounsfield unit is most likely to be hyperdense Bosniak 2 cyst. And this was like studies in different studies, and it tended to be benign in like 99% of the cases. Non-contrast Hounsfield unit density summary. Okay, so if you have lesions that is like less than 20, this is fluid attenuation. On the pre-contrast is more likely to be simple cyst, and there is no need for follow-up. If you have cyst with greater than 70, no follow-up because it's hyperdense cyst, so more likely to be hypertenacious cyst. If you have lesion between 21 and 69, it is indeterminate. And at this time, there is no agreement about if you should follow up this patient at certain time point or not, but most of the centers believe they are doing the follow-up between 21 and 69 Hounsfield unit in the pre-contrast. I will talk about the lesion on portal venous phase in later slide. Okay, so portal venous phase incident renal lesion. Okay, so if you are scanning any patient for any reason other than renal protocol, let's say you are scanning the patient for something in the liver and you are doing triphasic and you find incidental renal lesion on the portal venous phase. Okay, this was a study published in American Journal of EGR last year, and they found 514 incidental homogeneous renal mass between 10 and 4 centimeters in portal venous phase, and none of this mass, after they tried to do the renal protocol, they didn't find any significant lesion. It was zero, no mass out of 346 mass, which was clinically important. 72% of this cyst measuring Hounsfield unit between 21 and 30 Hounsfield unit. Okay, so if you are scanning the patient for anything and you find incidental renal lesion on the portal venous phase and Hounsfield unit between 21 and 30, it is unlikely to be significant renal lesion. This was published last year in EGR. Okay, so here when you should use CT and MRI. If you have a small renal lesions, it's better to use MRI. If you have hyperdense cyst, as I talk about this, hyperdense cyst, maybe you need to do subtractions. You need to think about maybe it has some pseudo enhancement because of like it has condensed content. Maybe it has some enhancement in CT, and you need to say if this is true enhancement or no. So MRI is better. If you have any patient with allergy to iodine, I think MRI is better for this patient. And if you have young patients, sometimes you have a patient with multiple syndromes like tubular sclerosis, like Van Hebben-Lindau lesion, tumors, and Burton-Hagg-Dubé disease, and you are bringing this patient to your hospital every 6 months or 3 months because you would like to scan this patient to see if this patient is developing a new renal lesions or no. So it is not preferred to scan this patient in CT, expose this patient every 3 months or 6 months or whatever you are bringing this patient for follow-up interval to scan this patient with CT. So MRI is preferred for young patient with syndromes that affect the kidney. Okay, so let's talk about the first renal lesion, and the first one will be angiomyolipoma. I would like you guys don't look at the lesion, just look in the visceral fat. So if you see this lesion is exactly following the visceral fat. Visceral fat means intraperitoneal fat, I mean. So if you look in the intraperitoneal fat or intra-abdominal fat, so you can see this lesion. If it is hyperintense, this lesion is hyperintense because this lesion has macroscopic fat, and macroscopic fat is exactly the same fat of the visceral fat. Okay, so if you look in this patient on the right side of the screen, you can see this is T2 fat set, and when you suppress the visceral fat, you are suppressing the lesion inside the kidney. So this is most likely angiomyolipoma because it has macroscopic fat. Okay, so here we can use this sign to differentiate between angiomyolipoma and liposarcoma. At the beginning of the lecture, I talk about one of the classic signs, which is how to differentiate between intrarenal lesion and extrarenal lesion, which is angiomyolipoma liposarcoma, to use Claus sign. And here the lesion has positive cloud sign. It is very subtle cloud sign. You can appreciate the second and third one, the right side of screen, and the middle one, which is the reconstructions and the sagittal and coronal. You can see this lesion has positive cloud sign with the kidney, and this lesion on right side of screen on the axial, you can see very large vessel. It looks like that's arising from the kidneys. It is more likely to be angiomyolipoma because liposarcoma lesion is not arising from the kidney. Lesion with negative cloud sign. Lesion was not is hypovascular, is not vascular lesion like angiomyolipoma. Okay, so clear renal cell is the second lesion would be clear renal cell carcinoma. Clear renal cell carcinoma is always enhanced in corticum phase 20 to 20 Hounsfield unit more in comparison to non-contrast CT. So the threshold for the enhancement is 20, as long as you have difference between the pre-contrast and post-contrast more than 20. That means that you have lesions that is truly enhancing lesion. Okay, so if you look on the left side of the screen, you can see axial contrast CT, and this lesion has enhancement, the corticum phase, and this lesion wash out in nephrographic phase. That's more likely to be clear renal cell carcinoma. Here's some common scenarios that's associated with clear renal cell carcinoma. Is bleeding. As if you look in the left side, left kidney, you can see renal lesion, soft tissue lesion. It is enhancing, and it is associated with peripheral like collection. This is clear renal cell carcinoma is hypervascular lesions. That's more likely to bleed. So this is clear renal cell carcinoma with pre-renal bleeding. So if you are encountering a case with bleeding, and this case is non-traumatic, you should put this differential diagnosis in your mind: ruptured ectopic pregnancy, if it is like a lady in a childbearing period, if you have hemorrhagic ovarian cyst, lying lady, if you have renal angiomyolipoma, this patient like have history of angiomyolipoma. Angiomyolipoma also is very vascular lesion, and renal cell carcinoma most likely will be clear renal cell carcinoma. Hepatic adenoma, this lesion are the most common lesions that has non-traumatic hemoperitoneum. Okay, so post-ablation, this lesion cells are dying and not infecting. Okay, so if you are encountering a lesion that is like clear renal cell carcinoma, and this patient, this lesion will use a cryoablation, and this lesion was ablated, and you see a gas bubble inside the lesion, that's not meaning this lesion is growing infection inside the lesion. That means the cell inside this lesion is dying. It's not it's not must to be infection. Here we have clear renal cell carcinoma with invasion of renal vein and IVC. And I was like, invasion of the IVC by tumor thrombus is not making this patient cannot get surgery. So if you have patient with invasion to IVC, you still can do nephrectomy, radical nephrectomy of this patient, and you can do something to fix the invasion to the IVC. So IVC invasion is not contraindication for surgery. Okay, here we have in the first algorithm, we talk about if you have any lesion with macroscopic fat, it is likely to be angiomyolipoma. If you have renal lesions that's enhancing, that is, you think about it as renal cell carcinoma, and you see macroscopic fat, it is more likely to be calcifications. Why you have renal cell carcinoma with fat? Because sometimes renal cell carcinoma is invading as the sinus fat, it is invading the surrounding fat of the kidney, and because it is malignant lesion, it's invading the fat, and this was fat with underlying dystrophic calcification. So if you have macroscopic lesions with calcification in the kidney and this lesion is enhancing, it will be clear renal cell carcinoma. So clear renal cell carcinoma, if it has fat, it is in most of the cases will have calcifications. So cystic renal cell carcinoma, MRI. So here we have a lesion on T1, and you see this lesion on T1 and T2 has a soft tissue component, which is not hyper intense like the cystic component in the T2. And after injection of the contrast, you can see this tissue is this part, the soft tissue component is enhancing in the T1 post contrast. So MRI can definitely characterize cystic renal lesion by identifying the enhancing soft tissue lesion. Okay, so if you have any mass with visible fat, how to manage? Okay, so you have incidental renal mass containing fat, containing region of Hounsfield unit is then negative minus 10 Hounsfield unit. That unit has macroscopic fat. So if you have calcifications, you should suspect renal cell carcinoma, and the next step will be a CT or MRI without contrast to further characterize of this lesion, and then you refer the patient for management. If you have lesion with no calcification and has macroscopic fat, is more likely to be angiomyolipoma, and if it is sanitary without any history of growth, so if the size is less than 4 centimeters, it is you don't need follow-up, because any angiomyolipoma that is like smaller than 4 centimeters, it is unlikely to cause any bleeding or any complication. If you have lesions that is larger than 4 centimeters, you need to refer this patient to management, to urologist, because it is more likely to cause complication, compressing or bleeding. Okay, so our next lesion will be so we still clear renal cell carcinoma. So here we have a lesion on so this lesion on in phase and out phase and enhancing. This lesion is enhancing, and this lesion shows some signal drop in out phase. That means this lesion has microscopic fat. So you should not use the signal drop in out of phase to diagnose angiomyolipoma, because angiomyolipoma actually it is macroscopic fat, and it will not show a signal drop in out of phase. Okay, so out of phase signal drop may be also associated with clear renal cell carcinoma. In this lesion, we can see some signal drop in out of phase, and it is enhancing lesion with contrast injection. So can we diagnose angiomyolipoma by single image at single slice at single sequence? Here we have a lesion. This lesion shown in phase, it is likely hyper intense in T1 and in T1 in phase. And in T1 of both phase, this lesion is not showing any signal drop. That means this lesion is not having any microscopic fat. But this lesion was surrounded by itching artifact, which is called the India ink artifact. And in T1 fat suppression, this is the sequence that suppresses the macroscopic fats. Okay, so and this lesion show suppression on T1 fat suppressed. Okay, so that means you have macroscopic fat. That means you are confident to diagnose this lesion as angiomyolipoma. But can we use in phase and out of phase to diagnose angiomyolipoma? Okay, so here we have physics slice. If this is the basic of the in phase and out of phase. If you look in one, like the slide on the right side of the screen, you can see like some light blue circle in the edge of the liver. Okay, so inside the liver you have mainly water molecules, and in the visceral fat you have fat molecules, and on the edge between the liver and the fat you have equal amount of fat and water. Okay, because you are sharing borders between area of macroscopic fat and area of water. If you look in the left side of the screen, what you are doing, if you in the beginning of the sequence, if you are sending the pulse at 0 millisecond, you have the in phase. Okay, so after 2.2 seconds, what's happened in the voxel in the area between the liver and the macroscopic fat? Okay, so they have equal amount of fat. If you look in the black circle on the bottom of the screen, you can see equal amount of fat molecules and water molecules. Okay, so at certain point they are out of phase, so they are canceling each other because they are fat and they are water. They have the same proportion of protons and fat, so they are cancel each other. So the out of phase, it's exactly the same as in phase. So let's say if you are segmenting the liver in phase, it would be identical to the liver in phase, because they are the same sequence, but you are picking the out of phase at the point at 2.2 seconds or at 4.4 seconds. This is applied to 1.5 Tesla. Okay, so you are picking this lesion at 2.2. At 2.2 millisecond, you have out of phase of the fat and the water. So you have the itching artifact. So the itching artifact growing between the macroscopic fat and the water molecule. So if you go back to this lesion, you can see the itching artifact surrounding this intra-renal lesion, but it's not suppressed. So that means this lesion has macroscopic fat and separated from the renal parenchyma, which has more water molecules. So if you have lesions inside the kidney that doesn't show signal drop in T1 fat set, that means that's macroscopic fat, and this lesion most likely in T1 or both phase would be surrounding by itching artifact. That means it is surrounding macroscopic fat lesion. So the answer is definitely yes. We can differentiate angiomyolipoma at single slice because there is itching artifact around it in opposite phase. Okay, so MRI lipid evaluation. So if you have MRI lipid evaluation, let's talk about it. Chemical shift imaging, it would be more likely microscopic fat, intracellular lesion, hepatic steatosis. It is microscopic fat, focal fat infiltration of pancreatic head, adrenal adenoma, microscopic fat, hepatic adenoma, well-differentiated HCC, clear cell RCC, fat suppression. Fat suppression, it is suppression of macroscopic fat. So you are suppressing, it is more likely subcutaneous or intra-abdominal fat. They are macroscopic fat, angiomyolipoma, dermoid cyst, adrenal myolipoma, lipoma, and liposarcoma. They are macroscopic fat. So they are more likely to be suppressed on the T1 fat set. Okay, so the next lesion is papillary RCC. Papillary RCC will show subtle corticomedullary phase enhancement or show very, very delayed enhancement. Okay, so here we have a typical lesion in the kidney, that is papillary RCC. This lesion in T and T2, in the first, the A is T2 lesion, and this lesion is you can look like characterize this lesion in T2, and if you look in the T1 lesion axial and you look in the post contrast, the corticomedullary phase, it looks like this lesion is not enhancing, and more enhancing in the late phase or the nephrographic phase. And if you look in the ADC map and the diffusion, this lesions look like it is had restricted diffusion, and after surgery, this lesion was proven to be papillary RCC. So how to differentiate between renal RCC and renal cyst, papillary RCC and renal cyst. So here we have two lesions in both kidneys. This lesion, one of them on right kidney, is not enhancing. And this lesion was the Hounsfield unit. If you read the Hounsfield unit pre-contra in the corticomedullary phase and the nephrographic phase or the early excretory phase, it is a renal cyst. And the lesion on the left side, left kidney, is a papillary RCC. You can see from this is look like as renal cyst. So sometimes papillary RCC can mimic renal cyst because it shows very minimal enhancement sometimes. So here we have a lesion on right kidney, a lesion on the left kidney, and pre-contrast and post-contrast. In the pre-contrast, you can see these lesions look like renal cyst. Okay, so but post-contrast, you can see this lesion was enhancing, and the nephrographic phase, which is later phase, and the renal cyst is not enhancing. The lesion on the right kidney was proven to be papillary RCC. Okay, so here is like how to differentiate between leofat containing angiomyolipoma and papillary RCC. So sometimes you have a lesion in the kidney. This lesion has angular interface sign, and this lesion has some area of fat. You cannot like put your mouse and see if it is macroscopic fat, or you cannot read the Hounsfield unit of area that is like the curved arrow here. This area look like as it is like macroscopic fat, but sometimes you cannot put your mouse and read it. So some CT scanners have softwares which is called pixel printout. So they are scanning the Hounsfield unit of every single pixel. So you scan this pixel, and if areas has macroscopic fat and angular interface sign, it is more likely to be fat poor angiomyolipoma than being papillary RCC. Okay, so here we have a lesion in the kidneys, this lesion in T2, and this lesion hypotension in T2 and has low value in ATC, restricted, and this lesion in if we look and the contrast, maybe I'm not sure, it's not enhancing. Okay, so this lesion is not enhancing. In the subtractions, it confirming this lesion is hypovascular lesion. Subtraction imaging, if you use the in phase and out phase, you can see this lesion is not showing any itching artifact, so you don't know if and doesn't show any signal drop. And I told you before, you cannot use a signal drop in out of phase to diagnose a lesion because sometimes renal cell carcinoma has microscopic fat and it may show some signal drop in out of phase. So after doing biopsy of this lesion was proven to be papillary RCC. Okay, so sometimes it's difficult to differentiate between fat poor and papillary RCC. So you need to put both differential diagnosis in your reporting, because if you see this scenario, if you encounter this scenario, you need to put low fat containing angiomyolipoma and papillary RCC carcinoma. And the difference between them, it depends on the clinical scenario of this patient. Maybe if this patient is losing weight and has some like different paraneoplastic syndromes, you can top both papillary before low fat containing angiomyolipoma. Okay, so sometimes can chemical shift to solve the problem to help to differentiate between low fat containing angiomyolipoma and papillary RCC? This is a new study was published in Radiology like 2 years ago. They used the chemical shift and in phase and out of phase to try to differentiate between the low fat containing angiomyolipoma and papillary RCC. So here we have a lesion. This lesion shows signal drop in phase, not in out of phase. So if you are encountering lesions that show signal drop in phase, that's means this lesion has some foci hemorrhage, okay? And this was confirmed by image D, which is chemical shift SY sequence. So this lesion show blooming artifact. This means this lesion has some bleeding inside it. So, they in their conclusion in their paper, they said if you are encountering lesions that like you cannot differentiate between low fat containing angiomyolipoma and papillary RCC, if this lesion has some intratumor bleeding, it is more likely to be papillary RCC. They take out this lesion and they do the pathology after surgery. It turned to be papillary RCC. So here we have another lesion in the right kidney, and this lesion doesn't show any signal drop in both direction, either in phase or out of phase. And after we use SY sequence, it doesn't show any blooming artifact. After they do nephrectomy, partial nephrectomy, they do pathology of this lesion. This lesion was turned to be fat poor angiomyolipoma. And this is a paper, so differentiation between papillary RCC and fat poor angiomyolipoma. It was preliminary study and they used different lesions. They found that the prevalence of intratumor hemorrhage is more likely to be with malignant papillary RCC than fat poor angiomyolipoma. So you can use your hemorrhage sensitive sequence to put your top differential diagnosis, okay? So I put back clear renal cell carcinoma to differentiate between it and papillary. It show prostate enhancement. Okay, so it show enhancement usually in corticomedullary phase. So you can appreciate the difference between clear cell and papillary RCC. Okay, so the next sign will be renal spoke wheel sign. Okay, so spoke wheel sign. If you hear about spoke wheel sign, you think about oncocytoma. But you should think about chromophobe RCC, because chromophobe RCC also can mimic oncocytoma. So here we have a lesion. This lesion was proven to be chromophobe RCC in pathology. This lesion has a spoke wheel sign. The central area has a spoke wheel sign, which maybe you think of, if you see this lesion and you think for the first time, maybe I would think about it as oncocytoma, but this lesion was turned to be chromophobe RCC, okay? So this lesion was enhancing inhomogeneously in the corticomedullary phase in different phases, but it has a spoke wheel sign. This lesion turned to be chromophobe RCC in pathology. So here we have again a spoke wheel sign, and this lesion turned to be an enhancing lesion with central area of hypo. It's not enhancing. Okay, central scar. It look like a spoke wheel sign. This was turned to be oncocytoma in pathology. Here we have this sign called segmental enhancement inversion. This was like using before as like people use it to diagnose oncocytoma, but right now some studies turn to be unreliable. It's not reliable anymore to diagnose oncocytoma. It was like if you have some areas that's enhancing and you have some scar or some fibrous tissue inside this lesion, it will enhance late. And the area that was enhancing is not, it turned to be non-enhancing in later phase. It's called segmental enhancement inversion. It's not reliable anymore, but I think if you see it, you should report it. So can PET-CT or anything can solve the difference between oncocytoma and chromophobe? And the answer is simply no, because Here we have oncocytoma lesions. This lesion saw avid uptake, FDG uptake, and this lesion was turned after surgery to be oncocytoma. So even with PET-CT, you cannot differentiate between oncocytoma and chromophobe RCC. Here, two studies, MRI features of renal oncocytoma and chromophobe RCC. I think it was published in EGR. And so the conclusion to this study, we have presented the largest series to date for the MRI feature of both renal oncocytoma and chromophobe RCC. This related cannot be differentiated between them. So they don't find any MRI features that can help them to differentiate between renal oncocytoma and chromophobe. I think this was the biggest study, like before last year, because last year Dr. Haytham Shibli was published a new study and it was bigger than this one. So you guys need to check it. Okay, so the one on the left side of the screen was differentiation between oncocytoma from chromophobe RCC. They cannot even differentiate between them. So simply it is not here differentiated. So renal, so spookweed side, maybe the invasion is more likely to be with chromophobe with malignant. So maybe you can use malignant invasion to put your top differential diagnosis, but they both differential diagnosis should stay in your differential in your reporting. Okay, so here we talk about before about the pseudo enhancement, and we have two scenarios to solve as a pseudo enhancement. If you have MRI, you should do subtractions, but if you have dual energy CT, you can do something called iodine mapping. So what's iodine mapping? Iodine mapping simply, if you have lesions that can pick up the enhancement in its soft tissue component, it will show yellow color. Okay, and when you are using the iodine mapping, it simply is the colorful one on the right side of the screen. So if we here in this kidney, we have all scenarios. We have four lesions. We have one on lateral side, we have medial lesions, we have two middle lesions. The two middle lesions had some soft tissue components, and as you see in the iodine mapping, you can see this lesion is enhancing, has some yellow colors inside it. So that's mean it is pick up the iodine, that means it has soft tissue component. The other two lesions, the one on the medial side, the one on the lateral side, one of them has pseudo enhancement. I'm not sure about which one. Oh yeah, I think the one on the lateral side of the screen had 36 and has some pseudo enhancements. Difference was 13. So if you are using the iodine mapping here, you can see this lesion is not enhancing, and this lesion on iodine mapping doesn't show any trace of iodine inside it. So you can solve the pseudo enhancement by two ways, using dual energy CT and using MRI by use subtraction. So here we have another lesion, this lesion in the kidney, and it was hyperactivating lesions. If you see the contrast not enhancing, and if you have this, it has some pseudo enhancement because it was 42, and it went up to 57 after enhancement. So if you see this lesion in the iodine mapping, this lesion was not picking up any iodine trace. That means this lesion is not malignant, is not having any soft tissue component. Okay, so here is a flow chart from the American College of Radiology. If you are encounter any solid renal lesion, so let's look in the right side of the screen. If this lesion is larger than 4 centimeters, you need to refer this patient. It is more likely to be a renal neoplasm. You need to refer this patient for nephrologist, for a urologist to do the nephrectomy or partial nephrectomy. If this lesion between 1 centimeter and 4 centimeters, you think about small renal neoplasm, and you maybe here you can refer the patient to urologist, or you can do a biopsy. If you have any lesions that's solid lesion, that's smaller than 1 centimeter, is more likely it is preferred to do MRI. If you have too small lesion to be characterized, it is more likely to be benign cyst. No further workup needed. If it is inconclusive, this lesion will be indeterminate. You need to do follow-up with MRI, either with 6 months or 12 months. Okay, here is a symbol of report if you are encounter any lesion in your kidney, not your kidney, sorry, and in any kidney in like MRI. Okay, so I think this is like a specific website. Maybe I will share it with you after the lecture or something. So if you have any lesion in the kidney, you need to measure the size of the lesion, the location in the lesion, the depth of extension, if it is invading the sinus fat, if it's invading the gluteus fascia, if it's invading renal vein, the IVC, the T2 signal relative to renal cortex. Okay, so and here is a common thing. People are looking for the T2 signal intensity in different parts of the lesion. No, you need to look for the T2 signal intensity in areas that is enhancing. So you don't like just ignore the other part. You just look at the areas that is enhancing and you check the T2 signal intensity. And here you are reporting your T2 signal intensity relative to the renal cortex. T1 chemical shift, as we talked before about the in phase and out of phase, diffusion, the enhancement, the segmental inversion enhancement, it's not reliable anymore, but maybe you can report it. And this is scoring how to clear renal sarcoidomal likelihood score. There is a specific website for that, you guys can check it. So fat-poor angiomyolipoma suspected, oncocytoma suspected, MR staging. So you need to, if you see this lesion, you need to tell the surgeon what's the status of renal vein is the anatomy, if it is like has any variant, if the renal vein is invaded, if the IVC is invaded, sorry, and the renal artery anatomy. And at the end, you are reporting your lesion and the enhancement, and the MRI finding is more likely to be in the top before differential diagnosis. So here is the graphic staging of the RCC. If you look up on the left side, you can see some lesions are smaller than 7 centimeters. So the T1 lesion is smaller than 7 centimeters, I think. It is like 2.1A and 2.1B. One is like smaller than 4 centimeters, and was smaller than 7 centimeters. And if you see T2 lesion, and the T2 lesion will be greater than 7 centimeters. So the next one will be T3, and the T3 is invading. And so T3A is invading sinus fat, is invading through the renal vein, is invading to maybe like the pre-renal fascia, and the T3P is invading the renal vein and is extending to the subdiaphragmatic IVC, and the T3C is invading the IVC supradiaphragmatic. And here the T4 will be invading like beyond the gluteus fascia, and invading the adrenal glands will be T4. Okay, so here is the regional lymph node and how you are reporting regional lymph node. Regional lymph node is the lymph node as long as you still see the kidney in the scan. So if you are scrolling and you still see the kidney, this is the regional lymph nodes, ipsilateral lymph nodes, and the next one will be metastatic lesions if you are see distant, like very, very far from the kidney lymph nodes, and if you see invading to the bones or the lung or liver or whatever, let's go. So metastatic renal cell carcinoma love lung because this is the circulation. So if you see the lesion go from the circulation go from the kidney to the renal veins and vena cava, the heart, then it is picked up by small circulation in the lung because circulation in the lung is very smaller and very fine. So any lesion will pick it up in the lung if it's go from the kidney. And here is like, it is very, so this patient has nephrectomy, radical nephrectomy like 20 years ago, and they incidentally find a hypervascular lesion in the tail of the pancreas, and this lesion turned to be metastatic RCC. Okay, so if you have patient, and I think the clue for this lesion was the clips here for the nephrectomy. If you are encounter hypervascular lesion in the pancreas, and this patient does not have any history of malignancy, you should think about intrapancreatic splenium, or you think about neuroendocrine tumors. If the patient has history of malignancy, you need to exclude renal cell carcinoma and malignant melanoma because it's enough to go to pancreas even after a long time. Okay, so here I have I think we have some, let me see. Oh, okay. This one. Okay. So can you guys name this syndrome? Okay, so this syndrome actually is tuberous sclerosis, which is brain and kidney. So this patient has multiple bilateral angiomyolipoma and had multiple bilateral calcified subependymal nodules. It is tuberous sclerosis. Next syndrome will be, can you guys name the syndrome?
Beard-Ruby disease.
Well, so it's Van Habelinda. Okay, good job. So This lesion is pancreas. The next one is pancreas and kidney. Van Hebben-Lindau. It is clear. It has multiple bilateral renal cell carcinoma and cystic pancreatic head mass lesions. Van Hebben-Lindau. This is like exactly the patients that need to be followed up by MRI, not by CT. Can you name this syndrome?
Beard-Dubé syndrome.
Okay, good job. So this part Hab-Dubé syndrome. This lung and kidney. So this lesion has multiple bilateral renal lesions and multiple bilateral renal lung cysts. So here is.
Doctor, could you repeat the name of the syndrome?
Okay, so let me go.
Beard-Hop-Dubé syndrome.
Okay, so the first one is tubular sclerosis, brain and kidney.
Mm-hmm.
Second one, pancreas and kidney, Van Hebben-Lindau.
Okay.
The third one is Barth-Hab-Dubé syndrome, multiple bilateral lung cyst and multiple bilateral renal lesions.
Okay. Thank you, doctor.
Simply, it is like cyst anywhere. Okay. Okay. So here we have, maybe when you are scanning the patient, you think this patient has multiple bilateral numerous in renal cyst, and you think about it as polycystic kidney disease. You need to exclude the psychiatric disorder of this patient. Okay, so this patient has mania or bipolar disorder, and this patient over on large dose of lithium. Okay, so lithium, one of the common side effects of lithium to have multiple bilateral renal cysts. Here is beautiful, very heavy T2, something like the MRCB, and this patient had multiple bilateral and numerous renal cysts, and this patient was on lithium. So this patient has large dose of lithium, was not polycystic kidney. And I want you do not emphasize on the central scar at any renal lesions, because any renal lesion can have central scar. Oncocytoma can have central scar. Pulmonary can have central scar getting large. Clear renal cell carcinoma can have central scar. Any lesion in the kidney can have central scar. Chromophobe can have central scar. So do not emphasize on the central scar at any renal lesions. And I think I'm done with the lecture, but I have this interesting case because I encountered, this is a real case, okay? It is not related to the topic, but I want to share it with you guys. So if you see this lesion, this patient was a 70 years old patient, and this patient was bisphosphonate for 2 years for treatment of osteopenia or something like that. So if you see this lesion, do you report it or no?
There is localized thickening of the cortica. Most differential diagnosis, we can say osteoid osteoma.
So
There is
you
localized
see some
thickening of the cortex.
Okay, this is called thickening of the cortex. In this case, some people report this was correct. Okay, the first part was correct. So this is called
compared to other side. This is leg. You can compare to the other leg, femur. I mean. To sure maybe congenital anomal or maybe congenitally this is present.
Okay, so yes, exactly. And many people say correct answer. This brief fracture. Okay, this cortical peak in case of bisphosphonate, you need to report it because this will be the next stage. This will be the next one. Will be like massive hilarious fracture for this patient, and the clue for this patient, if you have this patient with fracture, you can still see the peak of the cortex at the site of the lesion. It will have transverse massive fracture. This is called a typical fracture. It's called focal lateral cortical peak in patient with bisphonate, and will have a typical femur fracture. Okay, so I'm done with the lecture, and this is me, and this is the farthest point I have been ever to. This is like the most farthest point in the west of the earth. It's called the Pacific City, and I don't remember exactly the name of this rock. And sometimes the water has some tides, the ocean, and you can stand above it. So this was like in Pacific City. I love this photo so much. So I'm done, guys. If you have any questions, please let me know. Thank you.
شكرا جزيلا يا اسلام. يعني طبعا محاضرة هايلة جدا وفي موضوع صعب جدا. يعني بتبقى الأمور فيها يعني الفاينل دايجنوزس حتى بعد ما بنعمل الكلام ده كله يبقى برضو صعب إن احنا نوصل للفاينل دايجنوز في بعض الحالات. بس أنا عايز أسألك، هو إمتى بنعمل بايوبسي بقى في يعني إيه الانديكيشنز اللي احنا نعمل فيها بايوبسي؟
I believe like Mr. Sheila, if you think this lesion is not malignant, if you are in some people prefer especially in renal lesions, because most of renal lesion has like malignant like renal carcinoma and angiomyolipoma. They are hypervascular lesions. They don't like to do the biopsy, so they prefer to do the like partial nephrectomy. So if your top differential diagnosis is clear renal cell carcinoma and angiomyolipoma, the first step you need to refer this patient to the management. This is a recommendation of the American College of Radiology. You need to follow this patient to your urologist. He will do the partial nephrectomy, and then you do the analysis of this lesion by pathology. But if you think this lesion is not malignant, at the end of the day, you will still do the partial nephrectomy, because this is like, there is no universal agreement about this, because oncocytoma, you still do partial nephrectomy. Even if you biopsy it, you still do a partial nephrectomy. And the other lesions will be papillary RCC, is not vascular lesion. If biopsied, you will still do partial nephrectomy. So if your top differential diagnosis is malignant lesion, you need to do to refer this patient to management. If you need to do biopsy and you are in doubt, you can still do biopsy, but not in hypervascular lesions.
Okay, thank you very much, Dr. Islam. Thank you for all. We'll meet again next Friday, inshallah. Thank you. شكرا. السلام عليكم ورحمة الله. السلام عليكم ورحمة الله.